Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question about dermatology. As we say, the skin is the mirror of the body and the skin is the largest organ of the body. Thus we say the skin is the mirror of the body. Okay, a 34-year-old man attends the emergency department with a rash on his legs, which he says has been getting worse with the past 2 weeks. His GP started him on flucloxacillin 1 week ago. At the weekend, he visited the emergency department as the rash was spreading. He was discharged with the addition of clarithromycin. He has a past medical history of well-controlled asthma. He suffers occasional aches and pains in multiple joints but has never had any formal investigations for this problem. He takes no regular medications. On examination, his observations are stable and he is febrile. This means that he has no any infectious disease. The patient is febrile. He has a series of raised purple-red lumps on the anterior aspect of both his shins. They are painful and tender to touch. This wants to say that the patient has Erythema Nodosum lesions. The results of investigations are as follows. HB 145 gram per liter is in normal range. Platelets 300,000. It's not bad. White BC 9.6 thousand is also not bad. CRP 15 mg per liter, sodium 139 mmol per liter, potassium 4.5 mmol per liter, and calcium 2.5 mmol per liter. The patient's blood analysis and serum analysis is in normal. It is not. We cannot see any significant abnormality. Okay, the on-call radiologist has authorized this report. Okay, this want to say that the patient has no any infectious problem. The CPR is normal range, YBC is not bad, and the patient's Lipoidica is okay. The on-call radiologist has authorized this report. Chest X-ray. No focal consolidation seen. Oh, it's okay. No focal consolidation. Clear lung folds. The lung fold is clear. Some bilateral hilar lymphadenopathy, and this is important. Bilateral hilar lymphadenopathy with erythema nodosum. Okay, the patient has bilateral hilar lymphadenopathy and erythema nodosum. What is the most likely diagnosis? The most likely diagnosis: A. Sarcoidosis. B. Cellulitis caused by MRSA. C. Necrotizing fasciitis. D. Scrofluoroderma, which is a type of cutaneous tuberculosis. And E. Erysipelas. Okay, as we said, the patient has no any infectious. We have no any infectious data in the patient's Lipoidica and history. But the most suspicious here is sarcoidosis, because the patient has erythema nodosum and bilateral hilar lymphadenopathy. We usually see this pattern in chest X-ray or patients with sarcoidosis. Okay, the answer is sarcoidosis, as we said. Explanation: the description of this gentleman's rash is a classic picture of erythema nodosum. Together with bilateral hilar lymphadenopathy, this makes sarcoid the most plausible diagnosis. Okay, Shin lesions. The differential diagnosis of Shin lesions includes the following conditions: erythema nodosum, Pretibial Myxedema, Pyoderma Gangrenosum, and Necrobiosis, Lipoidica, Diabeticorum. Okay, the characteristic features: erythema nodosum, symmetrical erythematous tender nodules that heal without scarring. Most common causes are streptococcal infections, sarcoidosis, as we can see in this patient has sarcoidosis, inflammatory bowel disease like Crohn or ulcerative colitis and diabetes mellitus, pregnancy, and some drugs like penicillin, sulfonamides, and oral contraceptive pill. As we can see here, we can see symmetrical erythematous nodules which are tender in palpation. Okay, this is the characteristic of Erythema Nodosum. Pretibial Myxedema, which are symmetrical erythematous lesions as seen in Graves' disease. They are shiny orange pale skin, as we can see here. We can see symmetrical erythematous lesions which are shiny orange pale skin in observation, and we can see this situation usually in Graves' disease. Here we can see Pretibial Myxedema also. Okay, Pyoderma Gangrenosum, initially small red papule, later developed to deep red necrotic ulcers with a violaceous border, as we can see here. This is the lesion of Pyoderma Gangrenosum. In 50%, it's idiopathic but may also be seen in inflammatory bowel disease, connective tissue disorders, and myeloproliferative disorders. Okay, this is the features of Pyoderma Gangrenosum. And Necrobiosis Lipoidica Diabeticorum. Of its name, we can know that we can see this situation in diabetic patients. Necrobiosis Lipoidica Diabeticorum. Shiny, painless areas of yellow-red skin, typically on the shin of diabetics, often associated with telangiectasia, as we can see shiny yellow or red skin, which typically on the shins, as we said, we can see is on the shin of the diabetic patients, and we can see telangiectasia also. These are the features and specifications of Necrobiosis Lipoidica Diabeticorum. Okay, these were Pyoderma Gangrenosum, Necrobiosis Lipoidica Diabeticorum, Pyoderma Gangrenosum, Pretibial Myxedema, and Erythema Nodosum. These are the differential diagnosis of Shin lesions in different patients. Thank you for your attention.